Hello, good morning. We have a 38-year-old lady who is working as a teacher in a school who was identified to have hereditary hemorrhagic telangiectasia with idiopathic severe pulmonary arterial hypertension. She is under medical care for the last 3 years. She presented 3 years before with right heart failure and was identified to have significant right atrial and right ventricular dilatation, severe pulmonary hypertension, systemic pulmonary artery pressures. She underwent a diagnostic cardiac catheterization in 2013 that showed severe pulmonary hypertension with pulmonary artery mean pressures of 65 millimeters of mercury. Pulmonary artery systolic pressure and aortic systolic pressures were similar. During the course of evaluation with a CT pulmonary angiogram to exclude thromboembolic PAH, we also identified that she has hepatic angiomas, uterine angiomas, and retrospectively on questioning her, we realized that she has episodes of epistaxis, and that ultimately led to the diagnosis of hereditary hemorrhagic telangiectasia. She was started on ambrisentan and sildenafil citrate along with diuretics. Her symptom status is slowly deteriorating. She gets occasional episodes of effort-related presyncopal episodes. She has significant right ventricular systolic dysfunction on the echocardiography. She is being planned for a repeat cardiac catheterization today. Assess the hemodynamics on nitric oxide. See whether she is a responder to nitric oxide by doing a vasodilator testing, and subsequently perform an atrial flow regulator implantation. This device is a centrally perforated nitinol device with varying dimensions of 4 mm, 6 mm, 8 mm and 10 mm. This is to create a predictable intraatrial communication so that we can have a right to left pop off in order to avoid episodes of effort related syncope and presyncope, and also to reduce the right ventricular volume overload. The initial hemodynamic recordings, this is the right atrial mean pressure of 13 millimeters of mercury with prominent A waves. Show the right ventricular pressures. The right ventricular pressure is marginally suprasystemic with right ventricular end diastolic pressures of 25 millimeters of mercury. Show the pulmonary artery. The pulmonary artery systolic pressure is marginally suprasystemic. The aortic mean was 83 millimeters of mercury and the pulmonary artery mean was 74 millimeters of mercury. This shows severe pulmonary arterial hypertension. On nitric oxide, now we have catheters in the pulmonary artery and descending thoracic aorta. The pulmonary artery pressure is 133 by 46 with a mean of 76 millimeters of mercury, and the aortic pressure is 115 by 64 with a mean of 80 millimeters of mercury. So obviously there is no significant fall on the pulmonary artery pressures on nitric oxide. So she has no vasodilator response. The echocardiography apical 4-chamber view shows significantly dilated right atrium and right ventricle. We can appreciate a marked deterioration of the right ventricular systolic function. So there is a severe right ventricular systolic dysfunction. Intraatrial septum bows into the left atrium. The left atrium and left ventricle are squashed. Next. The echocardiography with the color Doppler shows significant tricuspid regurgitation, and when we measure the tricuspid regurgitation jet, it is around 108 millimeters of mercury, and when you do the TAP-C assessment for the tricuspid valve M mode mobility, it's 9 millimeter, indicating significant RV systolic dysfunction. The inferior vena cava is markedly congested. There is no inspiratory collapse, and the hepatic venous flow Dopplers are showing very prominent atrial systolic reversals. And when we try to look at the intraatrial septum again, we can appreciate that the intraatrial septum is markedly bowing into the left atrium. We can see spontaneous contrast in the right atrium and right ventricle, indicating that there is poor right ventricular contractility, and the forward flow of the blood from the systemic veins through the right ventricle into the pulmonary artery is very sluggish. So right now we are coming down on the transeptal needle. Yeah, so we have entered the left atrium. We have chosen a 10 millimeter diameter Occlutech flow regulator device cable. So the device has got a central fenestration. This fenestration is 10 millimeter. The waist in this particular device is 5 millimeter apart. So that means the left atrial disc and the right atrial disc are 5 millimeter apart. We have got three different sizes: 2 millimeter apart, 5 millimeter apart, and 10 millimeter apart. We have chosen the 5 millimeter waist device, and the central perforation here is 10 millimeter. The device has got a hub on the right atrial side, with which we catch the hub. So the device is now held by the hub, and once we know that it is secure, we load it into the sheath. So this is a short introducer sheath into which we load the device. So the device is now fully loaded in the sheath. So the device is being held by the cable, and now we are opening out the cable. She has gone into a flutter now. Flutter has terminated. And now, after hugging the intraatrial septum, so now we deploy the second component of the device. Now the device is fully deployed. And we can appreciate the red color flow across the flow regulator device, with flows from the right atrium into the left atrium. Acquire? Push inside. Yeah, like that. Yeah, that's good. In the post-procedural period, we monitor for oxygen saturations on pulse oximetry. It often falls to the level of 85 to 90%. We also look at stability of the blood pressures, the heart rate in the immediate post-procedural period. The pulmonary vasodilator therapy with bosentan or ambrisentan along with sildenafil will be continued indefinitely. So what we saw now was implantation of Occlutex atrial flow regulator device on patient with severe pulmonary arterial hypertension in order to prevent presyncopal episodes and reduce the right atrial pressures. This procedure has been tested in our institution in about 10 patients so far, and we monitor these patients for reduction in the episodes of presyncopal episodes. In fact, there should not be any episodes of syncope after the procedure at all, and we also monitor for improvement in the 6-minute walk distance and pro-BNP levels. This procedure has also been done for left heart decompressions, as in patients with heart failure with preserved ejection fractions or in some forms of restrictive cardiomyopathies, in order to relieve the left atrial pressure, where the device will flow from left atrium to right atrium. The device is available in 4 different sizes: 4 mm, 6 mm, 8 mm and 10 mm. By and large, we use 10 mm device in patients with idiopathic pulmonary arterial hypertension because we want a large atrial septal communication. However, on the left heart decompression, we tend to use either a 6 mm or an 8 mm device because we don't want to have a very large left right shunt. The procedure is reasonably simple. It involves puncturing the intraatrial septum in the region of fossa ovalis, crossing with a Mullin sheath and deploying the device across the atrial septum under echocardiographic guidance. This can be done on transthoracic echocardiographic guidance also. There is no need for a transesophageal echocardiography to guide this procedure. And the subsequent post-procedural monitoring will be by again thoracic echocardiography with contrast echocardiogram, where we inject agitated saline into the venous system and look for flow of the contrast from the right atrium to left atrium. The patency of the device is going to indicate the success of this procedure, and the long-term patency is maintained by combination of aspirin and clopidogrel, something similar to how we manage a patient after an atrial septal occluder device placement. Thank you.